Okay, once again, good morning, good evening, good afternoon from wherever you're calling from. Welcome to the thematic room 1, Pediatric and Adolescent Testing. My name is Irene Juguna. I'm a research scientist at Kenyatta National Hospital and a former CIPHER grantee. And before we start, I would like to explain a few housekeeping rules. We'll have 4 presentations of 8 minutes each. After the presentation, there'll be around 20 to 25 minutes of question and answer. Please send your questions into the chat function or verbally by raising your hand and waiting for me to give you the floor. If your question is directed to one speaker, specifically note that as well. Please be brief when you're asking your questions so that we allow as many questions as possible. And you'll note that you're all muted right now, but we'll go over how to unmute yourself and how to ask questions when we arrive at the Q&A session. Please keep your camera off throughout the presentation. This webinar is recorded and we'll also save the chat. When you're asking a question, please indicate your name and your contact details. We'll share the chat with the speakers at the end of the webinar, and they'll be able to follow up on questions in case we don't have time to address them here. Today we have 4 CIPHER grantees who will be speaking to us: Arnold, Alain, Sarah, and Tamzin. I'm now leaving the floor to our first speaker, Arnold Sadio. Go ahead and introduce yourself and start your presentation.
Thanks, Irene. Hello, everyone. I'm Arnold Sadio, Francophone 2020 CIPHER grantee, and I'm going to present you the summary of my project entitled Access to Self-Testing and Prevalence of HIV Infection and its Associated Factor in a Vulnerable Population, the case of adolescent in the street of Togo. Next slide, please. Hello, did you receive me?
Wait, Arno, I'm just going to take over the presentation. Just a few. Here you go. You can start.
Okay, thanks, Daphne. Okay, thanks. Like I said before, I'm Arnold Sadio, Francophone 2020 CIPHER grantee, and I'm going to present you the summary of my project entitled Access to Self-Testing and Prevalence of HIV Infection and its Associated Factor in a Vulnerable Population, the case of adolescent in the street of Togo. Next slide, please. So to describe the context a bit, I would like to say that Togo is a Francophone country in West Africa with an estimated population of 7.3 million people in 2018. The country is delimited to the north by Burkina Faso, to the west by Ghana, and to the east by Benin. The prevalence of HIV infection was estimated in 2018 at 2.3% in general population. According to UNICEF data, in 2016, it was estimated that there will be more than 5,500 street children and youth in Togo. Next, please. Okay, on this map, no, please come back little. On this map representing Togo, you can notice that the majority of street children and youth are mainly concentrated in the two largest cities of the country, namely Lomé in the south and Kara in the north. Next, please. So street adolescents are vulnerable to HIV and have limited access to sexual and reproductive health services and HIV testing. In 2016, only 14.8% of street adolescents in Togo reported ever having received HIV testing. Despite evidence that self-testing can significantly improve access to HIV testing for vulnerable population, self-testing has never been proposed or evaluated in Togo. Next, please. This is what motivated the present project, whose main objective is to describe the acceptability and feasibility of HIV self-testing among street adolescents in Togo. We will also estimate the prevalence of HIV in this population in Togo. Next, please. We propose to implement a two-stage cross-sectional study in the most populated cities of Togo. Like I said, Lomé, capital city located in the south, and Togo, and Kara, second largest city located in the north. 500 street adolescents aged between 13 and 19 will be selected using time location sampling methods. Next, please. This study will take place in two phases. Phase 1 will take place from January to March 2021 and will consist to describe the acceptability and feasibility of HIV self-testing using OraQuick, which is an oral test, and HIV 1-2 stat pack, which is a finger prick test. This phase will also estimate the HIV prevalence among street adolescents. Phase 2 will take place from July to September and will consist to explore and describe perception and experiences of street adolescents on self-testing and to retest adolescents who were test negative in phase 1. Next, please. The main outcome identified for this project are acceptability of HIV self-testing, defined as the number of participants who took the test out of the total number of those to whom the test was proposed. Feasibility of HIV self-testing, defined as the total number of tests with a valid result out of the total number of those who took the test or attempt to take it. And finally, prevalence of HIV infection, defined as the number of street adolescents test positive for HIV among the total number of participants. Next, please. 3 major challenges have been met or are expected in this project. The first one was ethical consideration about the participation of minors under 18-year-old. So in addition to the personal approval that will be absolutely necessary, it was decided and accepted by the ethics committee that the person in charge of the street adolescent, particularly NGOs member, will have to sign a consent for the participation of these adolescents. Secondly, the question of adolescent follow-up in case of a positive HIV test has arisen. To address this issue, it has been decided to involve clinic funded by the National AIDS Program and providing free HIV care. In addition, if there is sufficient reason to doubt the adolescent's ability to monitor and control his or her treatment, NGO staff will be called upon to accompany the adolescent until they become self-sufficient. Finally, the sustainability of the project must be ensured. That's why we decide to involve the National AIDS Program, which closely follows our works and which will be able to use the result for the benefits of street adolescents. Also, the involvement of the main NGO working with the street adolescent in Togo brings a certain assurance regarding to their follow-up beyond the study. Next, please. About the project status, things are going quite well. As you can see on this chart, from step 1 to step 3, we have completed the administrative procedure, in particular bioethic agreement, National AIDS Program agreement, and partnership agreement with the NGO. About the purchase of screening tests, we are still waiting for the delivery of the self-test. it is taking longer than expected due to the COVID-19 related disturbance. Next, please. So about the impact of the project, the implementation of this project will enable street adolescents to have a gateway into the health system using HIV self-testing. And the result of this project will benefit local NGOs for the implementation of successful evidence-based sexual and reproductive health intervention. Next, please. So I'm reaching the end of my presentation, and I would like to share with you this image. It is a capture of a documentary made by France 24 about street adolescents in Togo, where they talk about their experiences and share their dreams for the future. And I have to say that that documentary has inspired me a lot. So thank you for your kind attention. Your contribution and question are welcome. Thank you.
Thank you, Alain. Thank you, Arnold, for an excellent presentation. As a reminder, please note down your questions or put them in the chat box, and we'll address them at when all the speakers have spoken. The next speaker is Alain Amstutz based in Lesotho. Go ahead, Alain.
Hi, everyone. Thanks, Irene, for this kind introduction. And thanks, Daphne, for managing my slides. So then let's straight go into the topic. As I said, my name is Alain. I'm a physician by background, CIPHER grantee 2018. Living and working in Lesotho since more than 3 years. And I will talk about the first part of my CIPHER-funded project, which is the ADORE study, a mixed method nested study within a big RCT, where we looked at secondary distribution of oral self-tests during home-based HIV testing among adolescents. And this was a project together with different partners, with a local NGO called Solidarité here in Lesotho, the Swiss Tropical Public Health Institute, and the Lesotho Ministry of Health in 2 districts of the country in the north, in Butabute and Mogotlong district. Next slide, please. All right, let me take you straight to this side of the world, to Lesotho. Is a little country surrounded by South Africa with a HIV prevalence of about 25%. The entire country lies above 1,000 meters above sea level. Very rural. It's estimated that about 70% of the population lives in rural areas, and with poor infrastructure and with challenges accessing services. And that's probably also one of the reasons why home-based testing is a widely used approach. Next slide, please. Which we also saw in our own research and implementation together with the NGO and Ministry of Health, for example, in 2014, where we ran a big home-based testing campaign and showed a good acceptability of over 90% by the population. But usually the challenge is achieving a good testing coverage, meaning that all people in the surveyed area who live there really know their status. And that's why then, next please, in 2016, we performed or conducted an observational study to see if with weekend catch-up visits, we can increase testing coverage, which was successful, but of course was quite expensive, because you can imagine these door-to-door home-based testing campaigns going to those rural villages is not a cheap approach. And that's why we thought, why not using a more cost-effective, a simpler approach. And that's when we came up with the idea of the self-test in 2018. Next, please. And that was the idea of Hoseng trial, which we recently published in the Lancet HIV. Next, please. So to take you quickly through this umbrella RCT with the mixed method nested study. It was a cluster randomized controlled trial in over 100 villages in these 2 study districts. Very basic one-to-one allocation, control intervention, and the clusters were villages served by 1 village health worker. And in control villages, we basically run the usual home-based testing campaign door to door, and those who were absent or refused the blood-based testing on spot, they were referred to the clinic. Whereas in intervention clusters, we left for these people, we left oral self-tests, the OraQuick, the same test that Arnold was talking about. And then we trained in intervention classes. We also had one household member that we trained on the spot. And of course, there was in the test kit, there was a brochure of information in Sesotho, the local language. And we also trained the village health worker in these intervention villages to perform and conduct the follow-ups of the left behind self-tests and document the outcomes. And then we just simply looked at the testing coverage after 3 months. This was our primary endpoint in the umbrella project. And in the ADOR study, we looked specifically at the data for adolescents and young adults between 15 to 24 years old. And we added qualitative research with in-depth interviews among adolescents who used the test and among those who didn't use the test. Next slide, please. Just to give you a brief view on the setting, this is high up in the mountains in Mogotlong, where it regularly snows. Next slide, please. So that's the area where we performed the campaign for 6 months. You see here another slide of our team going from door to door, from village to village, and you can imagine that we all lost a few kilograms. Next slide, please. Here you see one of our team members explaining and training one present household member so that he then can explain in return to an absentee when this one is coming back and give him the left behind OraQuick. Next one. The results were recently published. The umbrella trial was published in Lancet HIV, and this ADOR study funded through CIPHER was published in the GIS. So for those who are interested, can get the details here. I will in the next slide just present the main outcome for the nested study. Next one, please. So what did we find? We had about 2,681 adolescents and young adults in our study, part of more than 3,000 consenting households. And what we saw in the control arm was that we reached about the testing coverage of 40% on the day of the campaign. That means on the day of the campaign, we could assess, we could verify the status of about 40%, be it because they had already a known status, or be it because we tested them, they accepted the test, and we had their result. And this looked very similar in the intervention. Next one, please. But the big difference came with the 120 days follow-up, because after 120 days, 37% more adolescents and young adults in intervention knew their status by basically using the self-test and letting it follow up by the village health worker. And you can imagine that this was a much simpler approach than going twice. We just went once into those faraway villages and then didn't go back again, just had the village health worker behind following up those self-tests. And you can also see that in the control group, not too much happened. Only 7 participants went to the clinic to get tested in these 3 months. Next one, please. Yes, and we also could see that this effect of the increased testing coverage was greater among male than female adolescents. Next slide, please. Then we went into more in-depth interviews and followed up adolescents who used the test and didn't use the test. Here you can see one of the participants. Next slide, please. And we had about 21 interviews, 11 who did not use the self-test and 10 who used the self-test. And we saw that adolescents expressed mixed views about the secondary distribution, weighing basically the confidentiality and convenience of testing, of not having to go to a health center, with concerns about insufficient pre-test information and counseling, because the test was basically left behind. As a key qualitative theme, the in-person assistance by either the trained household member or the village health worker behind was really emerged as one of the key themes. Next one, please. And you can see here a quote of one of our female participants, who is basically saying that she thinks it's a good thing because she does not have to go to the nurse, and she otherwise does not have many opportunities to get tested. So this was an easy way for her to know her status. Next slide, please. All right, and then I just noted a few discussion points that that might be interesting to discuss afterwards. We all know that community health workers or village health workers is a lay cadre that has been established in most other African countries, and there's an international push for more of these lay workers. So the model would fit into this policy direction very well. The same thing for HIV self-testing. But the big question is just always how to get now this research, which has been published and covered in several news outlets, how to get this now fully into policy and reality. Then the cost effectiveness is, I think, an important question, because the self-tests are a bit more expensive than the conventional tests. Consent process is always an important issue that we might want to discuss afterwards, and then maybe also some new ideas how to even improve the intervention. Thank you very much. Next slide, please. And with this, yes, just for those who are interested, there's a second CIPHER project running in Lesotho that looks more at service delivery among adolescents, which can be accessed on this homepage or read in the BMC trials, the study protocol. Yeah, thank you very much. And with this, I would like to close, and I'm looking forward to your questions. Thank you very much.
Thank you very much, Alain. That was a beautiful presentation. We'll transition to the third speaker, Sarah Skeen, based in South Africa.
Thanks, everybody. It's really lovely to be here. So thanks so much for the opportunity to participate. I'm going to speak today about a project where we're developing or adapting an evidence-based intervention component to promote HIV testing of young children, which is integrated into community-based parenting programs. Thanks. Next slide, please. Of course, there are many different people involved in this project, just to say, and both of these initiatives that you can see on the screen have got many different partners who are involved. So I'm very happy to represent them. Basically, the point of the project is to take an intervention that was developed as part of the Early Morning Star program, which took place in Okotlong in Lesotho, and adapted for use in South Africa, in isiXhosa, and for testing in Khayelitsha, which is near Cape Town. And what we're doing is we are embedding the content into a different parenting program. So the Early Morning Star program was a specific type of community-based parenting project. We are taking that content and embedding it into a different parenting program called Sino Kids. It's also known as Parenting for Lifelong Health for 2 to 9-year-old children. And it's actually a global initiative to promote positive parenting that's being run through the WHO. So we are looking to fit and adapt our intervention content to fit within this global program. Next slide, please. Just to say that we did a cluster randomized controlled trial of this content as part of the Mpatlalatsane project, and it was very successful in promoting testing of young children under the age of 5. So now what we've done, I'm a 2019 grantee, and a lot of this work happened at the end of 2019, the beginning of 2020, before lockdowns have delayed some of the phase 2, which I'll get to in a second. Phase 1 consisted of gathering stakeholders' opinions on a range of issues relating to parenting in the context of HIV in Khayelitsha, and also contextual issues that might influence how we deliver the intervention, as well as how parents are able to take up testing for their children. That involved us speaking to parents, including new mothers, as well as community workers, parenting program facilitators, and HIV experts. And at the moment, we're using those interviews to adapt the intervention materials. Next slide, please. This just gives you a brief overview of some of the results that we got from those interviews and focus groups. The general concerns of parents included very much a strong focus on issues relating to safety, there's high exposure to violence, concerns about poverty, lack of access to quality health and integrated HIV care, and also the large burden that's placed on female caregivers. Parents felt that, or parents and other stakeholders that were interviewed felt that there's a real need for age-appropriate information on child health and development, including on HIV, about parenting, especially for fathers who mentioned several times, improve social support networks, and improve relationships with partners and ex-partners for how to co-parent children where parents were not in a relationship. Specifically looking at HIV-related themes, it was clear that people felt that there was a need for more information about how children can be infected by HIV/AIDS and why and how exclusive breastfeeding can actually protect children. There was still a lot of mixed understanding about that. A lack of community knowledge about exclusive breastfeeding, meaning that often moms were targeted about the importance of breastfeeding, but other community members didn't have the same level of information. And really strikingly, many concerns about stigma, which was still, we found, affecting testing and willingness to test, disclosure to family members and others, and then also affecting adherence for both adults and children in this community. Next slide, please. So what we've done is we've distilled the focus group information and the original intervention content to make 4 key messages, which are going to be delivered through this community-based parenting program. So the program is actually delivered just to the general population. It's a universally delivered program. So although the HIV infection rate is very high in Khayelitsha, many of the parents who are receiving the program may not necessarily be infected by HIV themselves. So it's kind of an HIV-affected community, we might say. And one of our key messages is just that HIV actually affects all of us. So just because we're not infected ourselves, it may be, we can all still be affected by HIV through family members and community members and our partnerships and that kind of thing. And part of that is to understand that HIV is not just an adult's disease, it also affects children. The second message is that young children can be infected. So you can be infected during pregnancy, birth, but also after birth, because we really found that there was a gap in understanding around those issues. And that even if a mom has had PMTCT, they should still test their child later on. Next slide, please. Then the third message is around the importance of HIV testing, that it's important for everybody, adults and children, and that the sooner that someone gets tested, the sooner they can get medicine that they need, which will keep them healthy. And then the final message is a sort of slightly less focus area, but the fact that when children and adults take their medication every day, that they will be able to maintain a healthy lifestyle. Next slide, please. So what's really important in delivering these messages is that the group is seen as a supportive learning space. It's not just about information sharing and telling people what they should and shouldn't do, but it's also about trying to find ways for people to be able to actually put these things into practice. And this really came up a lot actually in the original project, which took place in Lesotho, where people wanted to go and have their children tested, but when they actually got to the clinic, the sisters in the clinic discouraged people from having children tested because they weren't sure what the purpose was. So we try to look a lot at how to problem solve around those things, whether it means going with a friend together or approaching different ways of solving the problems. And we use very participatory methods in the group as well. Next slide, please. And this just gives you an overview. So on the left-hand side is the kind of parenting content that you can see. And what we're doing is similar to what we've done in Lesotho, is adding in a child health component as well. So the focus of the program, is part of the framing of the program, sorry, is to say that your child requires lots of different things to keep them healthy and happy. And what we do is we slowly introduce the child health quite generally, and then focus on the HIV content a little bit later on in the session. So as not to kind of raise too many alarm bells or increase any kind of stigma around attending the program. Next slide, please. So what we're doing early next year is starting our pilot project with 120 parents, which we're very excited about, especially, hopefully we don't have any further delays with lockdowns. And we're really hoping that, if it's successful, that we can do further rollout of the program and further evaluation. But also we are very excited about linking for parenting for lifelong health. for the possibility of taking the program or the components to be integrated into their program in different places as well. So Parenting for Lifelong Health are developing open access, non-commercialized parenting programs, and they're currently working in 20 different countries. And the other, besides this testing focused content, there's also potential working with them to develop further content for HIV positive parents and looking at specific issues around parenting whilst living with HIV as well. Thanks very much.
Thank you, Sarah, for an excellent talk. The last speaker is Tamzin Phillips, based in South Africa.
Hi, everybody. Thanks very much for the opportunity to present here. So I am based at the University of Cape Town in South Africa, and I'm a 2020 grantee, so just getting started. And my project will be using routine electronic health record data for mothers and infants to support retention and postpartum HIV services. You can leave it on this slide, Daphne, that's fine. Yeah, so to support HIV treatment and early infant diagnosis. So we all know there have been huge advances in reductions in mother-to-child transmission of HIV over the past decades. And the spectrum model stacked bars is a really nice way of, their PMTCT analysis is a nice way of looking at gaps in PMTCT and prioritizing areas for intervention. So this is the South African stacked bars from the latest UNAIDS data. And you can see clearly that a large proportion of new child infections take place when mothers drop off of their ARVs during pregnancy or breastfeeding, or due to other reasons for viremia during pregnancy and postpartum. So being able to identify moms who are out of care or viremic and then prompt, make sure children are tested as they should be through PMTCT are critical areas of intervention. Next slide, please. So this project aims to use a robust electronic routine medical record system to prospectively identify and trace mothers living with HIV and their HIV-exposed babies who have gaps in routine PMTCT services up to 9 months postpartum. And this is based on the data to care approach that's endorsed by the US CDC and used in other sort of higher resource settings. Where routine HIV surveillance data is used to identify people living with HIV who have dropped out of services and facilitate their linkage back to the care that they need. Next slide, please. So this project will be based in Gugulethu, which is an urban township area in Cape Town. Large population, the clinic in Gugulethu serves a very wide area, not just the sort of local Gugulethu community. People come from quite a wide area to access antenatal services at the MOU there. There's high levels of unemployment and poverty and a high HIV burden, estimated at around 25% antenatal HIV prevalence in 2017. And HIV and other primary care services like pregnancy care are provided free of charge in this setting. Next slide. And one of the challenges here is that although women get integrated antenatal and HIV care during their pregnancy, after they deliver their baby, they are transferred out to continue their HIV care at a routine HIV clinic, and the baby is transferred to a well baby service, which may or may not be in the same clinic. So it's quite difficult to monitor PMTCT throughout the PMTCT cascade as women move after delivery to different clinics. So this is just the map. There are 10 other ARV clinics providing HIV services just within sort of a 5-kilometer radius of the MOU. Next slide, please. So we're very fortunate in the Western Cape of South Africa to have a very robust health information system. We use a unique patient identifier in all primary health care clinics in the Western Cape, and these are linked together through our provincial health data center that take data from hospitals and laboratory databases, pharmacy, and the sort of clinic administrative databases, and link them all together based on this unique identifier. So we're able to trace women and babies through the PMTCT cascade using this electronic data system. And this project will make use of existing patient level reports for HIV and child health. Next slide, please. So the project will be based around a prospective cohort of 400 women living with HIV and their HIV-exposed infants who will be enrolled shortly after delivery in Gugulethu, and we'll follow them through till about 9 months postpartum and expect to observe between 80 and 120 gaps in routine PMTCT, including missed, so we'll be able to identify whether a child misses a 10-week or 6-month PCR test, whether the mother has linked to HIV care after she delivers, and we'll look for completion of viral load, and also obviously to identify any baby that has tested positive for HIV and make sure that they've linked to HIV care. So the first aim will be just around using the routine reports to identify these gaps and validate them using various data sources, including going into the clinic and looking at clinic records. The second aim will be to prospectively trace these mothers and babies, identify reasons for gaps and barriers, and facilitate their linkage to care, while also ascertaining the success of that linkage. And then we really want to explore opportunities and challenges around using this approach more broadly, and we'll use an implementation science framework to guide in-depth interviews with mothers and key stakeholders to understand how best the routine data can be used, and also to refine what the tracing approach might look like. Next slide, please. So we've recently received ethics approval in October, and actually just in the last couple of days received our final Department of Health approvals. So we're hoping to start recruitment in January, and we're working quite closely with the Department of Health to finalize the tracing plans to ensure that we align with the local processes and that the systems we set up are realistic and feasible in this setting. Next slide, please. And the potential impact, I think, is really to streamline the identification and tracing of mothers and babies with gaps in PMTCT, with the potential to improve individual and program outcomes. And then to identify barriers and facilitators of using this approach that would help to adapt it and scale it up in other settings. We really want to strengthen the routine data at the same time, so there'll be positive feedback loops built into the process throughout to try to strengthen the routine data. And one of the outputs of the project will also be a refined report specifically for PMTCT gaps that will be able to be used in other parts of the Western Cape. Next slide. And lastly, just to thank my mentor, Land and Maya, and my scientific advisors, as well as the Department of Health, who've been hugely helpful in just conceptualizing and putting this project together. Thanks very much.
Great. Thanks, Arnold, Alain, Sarah, Tamzin, for the excellent work that you're doing and very stimulating talks. We'll now move into the question and answer section. And as a reminder, please send your questions in the chat box. Thank you for those who have already sent questions. If you'd like to send your question, to ask your question verbally, just use the raise hand function or just text, I have a question in the text box. And if the question is directed at one speaker, please note that as well. And before you ask your question, please briefly introduce yourself. So as we wait for people to raise hands, there's some questions in the chat box for Arnold, and I'll ask two questions, one bunch related to the context. So Arnold, could you give a bit of details? There's a question from Dr. Mfo about the age of consent for HIV testing in Togo, whether there's index case testing happening in Togo, that's from Ndri Have. And then also what happens for whether there's any experience on HIV testing in non-street children, adolescents, a question from Dustin Mandala. Maybe we can start with that bunch for Arnold.
Okay, thank you, Irene. So about the age of consent of HIV testing in Togo. It's important to say that in Togo, the ethics committee considers consent to be valid from the age of 18. Under 18 years of age, the signature of a responsible person is required in addition to the approval of the minor. So I don't know if it's clear. about any experience of HIV self-testing among non-straight adolescents in Togo, I have to say that a year ago, the National AIDS Program received a stock of oral quick tests in order to assess their intrinsic characteristics. However, these evaluations were carried out in the general population, and no acceptability studies were done. So vulnerable population were not involved. This will be the first time in a vulnerable population in Togo. About index testing in Togo, I have to say yes. The index testing approach is applied in Togo. Generally, in case of a positive test, during counseling of HIV positive person, HIV positive person is invited to inform his or her partner so that the latter can be benefits from the test. To my knowledge, this approach has not yet been evaluated. So I'm going to say something. I think that if self-testing was part of the diagnostic strategies in Togo, we could simply give the test to the positive person and tell him to make it carried out by his partner or her partner. So for the moment, self-testing is not part of strategies in Togo, which is why we are going to take advantage of this study to evaluate acceptability, feasibility of two types of self-testing, oral self-test and finger prick test. National programs are really engaged with us. So I think we will do, the result will be used for the good things. Irene, I don't know if I forget something.
No, that covers it, Arnold, and feel free, Dr. Mfondri and Justine, to follow up in case there are more questions. Another question for you, Arnold, from Jane Mutanga is, sounds like there's a lot of NGO work going on, and how do all the adolescents have access to an NGO, and what happens to those who don't have a connection to an NGO?
Okay, so yes, there are several organizations working with street adolescents in Togo. The two organizations that we will be working with are Ange. Ange is Friends for a New Generation of Children. And the second one is Agopod. Agopod is Agora for Disadvantaged Population. These associations have social home, but of the time they are on the ground, they know the place where street children often gather. It is mainly the beach of Lomé and around the market of Lomé. And they have to go to meet them every time. Sometimes they manage to find the families and reintegrate them. Unfortunately, not all children benefit for their service because many are in transit in Lomé, often coming from Ghana or Nigeria. Irene?
Okay, thanks, Arnold. And please feel free to raise your hand or send a text if you have a question, just to follow up in case the question was not completely answered. There are some questions here for Alain, and questions regarding acceptability of home-based testing. Irene Nakatude and Jane Mutanga are asking about stigma. Is there a stigma in the villages? And have you experienced challenges in encouraging people to participate in the study? And then what are the reasons for refusal to test?
Thank you very much. That's a bunch of questions, but I'll start. You tell me if I didn't cover everything. So I think what's important regarding the acceptability of home-based testing There's quite a lot of data from Lesotho and the surrounding settings, but Lesotho specifically, that it is quite well accepted. And probably one of the main reasons is that really people appreciate when there's an effort made coming to them to far away villages in the rural areas here in Butha-Butha-Mokhotlong. So usually we have acceptability or uptake rates of more than 90%. This is a little bit lower among the adolescents, but the bigger problem is rather the coverage, so that especially the young ones and the men, they're often not there. So you find the women, you find the elderly ones who are home, and the others you miss. And that's why the self-testing is quite a promising approach to put it up as an add-on during a home-based testing. But generally speaking, we see good acceptability rates, especially if you combine it with other services. So I didn't explain too much into detail, but this was not just a HIV testing campaign, but we provided other services and other screening, of course also tuberculosis screening and stuff. So it was not just about HIV. Now, in terms of stigma, yes, we cannot deny that. Although there's a lot happening in Lesotho, and a lot of information passing in the news every day about still about HIV. So the HIV is in everyone's mind, but that doesn't mean that there's no stigma. We don't have now stigma data from our participants in the villages. We just have some proxy data from our village health workers. So those who collaborated with us, they all underwent 2 trainings, and as part of one of the trainings, we assessed their stigma scores with a 8-item scale validated score, and saw that their stigma, HIV-related stigma, is very low. But again, these are all experienced village health workers who work in the field of HIV since many years, so they might not reflect like the general village population. And I think that brings me a bit to the last point around disclosure, stigma. Important to know, and also support of the study, it's important to know this, that it's not that we just left the tests behind and there was no support system. So we, of course, on the day of the campaign, we did this with our counselors, and these are all experienced counselors who do this every day. But then we also trained the village health workers behind, basically after we left the village, to follow up these tests. And as said, they all got 2 trainings, a basic HIV HTS training, and they were all already trained on HTS before. So this is a network that already exists from the Ministry of Health that we collaborated with. So these are not new people, and that's why they already brought into a lot of experiences, which is great for us. And then they got a specific training, of course, on the OraQuick, which was still new by the time, so 2 years ago. Now it's already quite widely used, but by that time it was new. So we organized another specific training for them to also tackle issues like disclosure after testing when they go by and they encounter cases, and how to go about, how to link to the health center. And that's what they already do every day, these village health workers, also in the controls. And the control, the only difference was they would still support them getting tested, but not with the self-test. There were no self-tests there, but they supported them getting tested at the clinic. This little add-on of a self-test leaving behind reduced, of course, the structural barrier of going to the clinic, walking 2-3 hours, or spending money of going to the clinic, which was a simple add-on for us. With a big impact. Now, in terms of more like competence and how well was the test used and why was it refused, so I didn't show you the acceptability rate of the OraQuick itself. I just showed you how it increased the testing coverage, which was 500 more people knowing the status, but it doesn't mean that everyone used the test. So the acceptability rate of the OraQuick was only at around 58%. which we expected. I mean, we did not expect everyone using the self-test, then really something would be wrong or something forced probably would happen, but we had an uptake rate of about 60%, which I think is quite, if we compare this data to other settings, this is probably quite realistic what we can expect from secondary distribution. Still, it has an impact because those who test, they know the status. And what's also, and if you talk about refusal reasons, we don't have all the refusal reasons, of course, but we have some reasons from the interviews, in-depth interviews. And there it was not so much about that it was hard to use the test or they struggled with it, because also there is data from Lesotho that the OraQuick is easy to use. They validated this before in Lesotho. But we got then more reasons really around confidentiality, that they didn't feel comfortable to do a test now in the household on their own. They felt like there's not enough assistance. They want to have a professional besides them who helps them and explains again. So I think for some people this truly does not work. But if we can get 60% more with just going once to a village, this might still be cost effective.
Great, thank you, Alain. That addresses the questions. Maybe just to follow up on what you talked about, competency level and how the adolescents were able to do the test and whether they did it correctly. Question from Jane Mutanga. Could you talk a little bit about that with regard to the self-test?
Mm-hmm. Yeah, so we basically know that 60% performed the test. We know from our interviews for those who used the test that this was really an easy to use test. They really appreciated the easy to use. They also appreciated the blood-based, the oral fluids instead of the finger prick. And I said, for those who did not use the test, we didn't really get many reasons around it was a difficult test. They didn't feel competent enough to perform the test. So yeah, although I think we also got a few interesting points of those who didn't use it. They also said maybe if we would add even more support, let's say an audio or some video follow-up or something. So there were some interesting ideas around how to make it even better. But generally, we felt that it's an easy to use test, and this was not the main reason for refusal. And there is some data, not from us, but from ICAP, who also presented some data at the conference last year or 2 years ago about self-testing, acceptability, and easy to use in Lesotho. And this was not... was shown to be actually an easy to use test. We had a brochure together with the test kit that was in the local language with some pictures and pictorial leaflet. And this has been used in other settings and validated in other settings, not specifically in Lesotho or in Lesotho, but in very similar settings.
Thanks so much, Alain. There's some questions. Maybe let's move to Sarah and then we'll come back to questions for Alain and Arnold. So Sarah, there's a question from Judy Mashuka, who's asking about community participation in the content development of the adaptive material to facilitate translation to local languages, and what interventions are in place to enhance sustainability. It's 2 questions from Judy Mashuka.
Thanks, Judy. Those are both excellent questions. I did cover it in my presentation, but they very much are, the intervention contents is very much adapted together with community partners. And there's 2 specific ways. So first, we have a community advisory board and we did this in the previous project in Lesotho as well as in the current South African project. And they basically have the final say really on the materials. They participated first in the focus groups, and then they were sort of indicated interest in being part of the advisory board, and then they've been opted into the advisory board. And what we'll do is have a series of workshops before the pilot starts to finalize materials with them. And then the other thing is in the Khayelitsha team, actually, and also previously in our previous project, our team members are very, very experienced in intervention, adaptation, and delivery. They are all from the Khayelitsha community, and so they also provide input as we go through the project as local experts. as well. So we have two kind of different sets of people assisting us with that. In terms of the sustainability, so this is still, we sort of still see this as the kind of development of the intervention and the kind of slotting of it into the parenting program. But we are trying to do that with thinking forward about scale up and sustainability. And the way that we're doing that is by partnering with that organization who is partner of the Parenting for Lifelong Health initiative. So they're called Clowns Without Borders South Africa. And they actually, their model of working is not to deliver the interventions themselves, but they have capacity building of other community-based organizations, how to run the program. So it's run all over South Africa and obviously in other places as well. And they have a really excellent kind of training and supervision system where they capacitate CBOs to run the intervention themselves. It's not, they aren't the gateholders, the gatekeepers of the intervention, if only they can deliver it. So they've got a really great track record with that as well. I hope that answers the questions. Thanks.
Thanks, Sarah. Let's move on to Tammy. Tammy, there are two questions for you here. What's the rationale for the 9-month postpartum follow-up? This is from Irene Nakatude, and also a question from Ida Mokole. What will be your approach for tracing mothers and infants with gaps in care?
Hi, thanks very much for those questions. So the 9-month rationale is unfortunately feasibility. I would very much like to follow the moms of babies through to 18 months postpartum, which is our sort of exit from PMTCT in South Africa. But with the 2-month funding, the 2-year funding, that's not possible. So we're focusing on the sort of early postpartum period. As we know, a lot of moms get lost from care in the first 6 months. So 9 months of follow-up will take us through to at least the 6-month PCR test. And if it's possible to extend beyond that, we definitely will. And then the tracing will probably be telephone calls predominantly, and then at least one home visit if we don't have success over the phone. So part of the project will also be when the woman is enrolled, we'll update her contact information in the clinic administrative system so that we know that we have up-to-date contact details for her. And we'll also record all that information. Like, did we manage to get through to her? Did we have to speak to her next of kin? What were the challenges in that space and things that could be strengthened through the tracing process?
Mm-hmm. Thank you for that response, Tamzin. There are quite a number of questions on disclosure for Arnold, Alain, and Sarah, and I think I'll combine all the 3 questions and then we can have all of you respond. So for Arnold and Alain, there are questions from Lewell Miranda on how adolescents will cope with their HIV status and how you support that disclosure process, whether the study is involved in that support. And then a question to you, Sarah, from Jane Mutanga, whether they are tailored, whether the message is tailored to parenting approach to disclosure of parents' HIV status to their children. That's if the children are negative. I think a very sensitive topic. So maybe Arnold first, Alain, and then Sarah.
Okay, thanks, Irene. So about disclosure test results, I have to say that initially we had the idea that the participants could take the HIV self-test externally and come back to us with the results. But under the advice of a sociologist working for an NGO and considering the lifestyle of these children and the proximity between them, this choice no longer seemed judicious to us to guarantee confidentiality. So we chose to carry out a supervised self-testing in a healthcare facility and accompany the result with psychological and social support. I don't know.
Great, thank you. Thanks, Arnold.
Yeah, in our study, we had the support through the follow-up of the village health workers. I mean, on the day of the campaign, of course, it was still us, the study team, with experienced counselors, experienced and trained counselors. And then in the follow-up, it was the village health workers, this existing lay cadre who is already there, who is very experienced, who we again trained twice on these issues, including disclosure issues. And they are actually supervised and linked to the nearest health clinic, where they can refer adolescents, where they cannot, if they cannot handle it, where they can refer adolescents, who, of course, for the linkage after the testing and so forth. So this was our kind of support, not through the study team again, but through the village health workers.
Thank you.
Sarah here. The short answer is that we haven't included any content on disclosure because this version of the intervention is still targeted at the general population who may or may not be HIV positive. But we do hope in future to develop content for HIV positive parents specifically. So at the moment, we don't have that included. Thanks.
Thanks, Sarah. I think we've covered most of the questions that they were asked. There's quite a number of questions, I think, with adolescents regarding consenting, regarding disclosure, regarding competence and acceptability of testing. So I think it's questions you can keep in mind as we continue to do our work. I would like to thank you all for coming to this session and really thank the speakers for excellent and stimulating talks. Thanks to the audience for your questions and very thoughtful and excellent questions to think about as we do our work. So I think that's the end of the session. Thank you all for coming. If you have more questions, please feel free to email, I think, the CIPHER team or email the participants who are presenting today. And thank you all for joining.